We have a lot of Kenyans going to India to seek cancer treatment. And we have seen cases where people or some doctors say after they have gone to India, they've received their treatment, they come back, either they will not last even 1 year because of the treatment, or after the treatment that they received in India, or they come back, unfortunately, having died. Yet families, relatives are really spent a lot of money in taking somebody to India. As a media, we also receive a lot of appeals of people raising funds to go to India. Is it that India has better care, or what is it about our health system, or you as doctors offering care, cancer care, do to make people actually go to India more than get treatment here locally?
As a country, one, we don't have enough general surgeons to go around the country. If you look at the numbers of general surgeons from the board's registry, they're around between 300 and 400 that are retained in the registry. And you use that against a population of 45, 50 million. And you're talking about maybe one surgeon to 400,000 people. That is certainly not enough, according to the WHO and the Lancet indicators. So we don't have enough surgeons, let alone surgeons to do oncology work. But the way the surgeons in Kenya are trained, they're able to take care of most of the cancer patients. So if we train enough surgeons, there will be enough people to take care of cancer. Of course, I know there is a specific cadre or specialty that is upcoming that is called surgical oncology, where surgeons are specifically trained to take care of cancer. In Kenya, we still train surgeons that are able to take care of cancer and take care of others because we are few.
We know that cancer is multidisciplinary.
Yes.
What do we mean by a multidisciplinary approach to cancer, and what exactly happens? Just take us through that.
Let me use an example of breast cancer. So if I see a patient, most often solid tumors, tumors other than tumors of blood are called solid tumors. Most of the solid tumors will require, probably they will see a surgeon first, right? And in the process of treatment, you will require to make a diagnosis. For you to make a diagnosis, you need imaging, either ultrasound, CT scan, MRI, to get an idea of what are you dealing with. Then you will need tissue biopsy. Now, imaging are done by a cadre of doctors called radiologists, and then tissue biopsy are done by a cadre of doctors called pathologists. Then you have a surgeon, and then after surgery or before surgery, you may need to give them chemotherapy that are given by a cadre of doctors called oncologists. And then after that, they may need radiotherapy, and that is given by radiotherapists. And then, of course, because they're cancer patients, their metabolism is high, they will have problem with nutrition, they may need a nutritionist. And if you're in an hospital setting, you will have cancer nurses that actually are involved in the process of giving drugs. And some of the cancer patients will require physiotherapy. Now, why we call it multidisciplinary? Because all these guys are needed, but it is better if they discuss patients when they are all seated. So they see that patient as a whole. So the pathologists give their contribution of what they think the disease is, the pathologist and the radiologist, and the extent of the disease. And then the surgeons and the oncologists and radiotherapists then make a plan together, so that, because sometimes if we are in silos, if we are in a separate places, you may send a patient to me, and then I have a question, and then I have to send a patient back to you, so that process can take time. But if we sit in one place and discuss the patient together, then we have an idea of what we are dealing with, so that when the patient comes, let's say, to surgery, I have an idea of the whole spectrum of how the patient is going to be managed. And then the patient is also informed of who they have to meet in the process of their management, what each person is going to do. And it shortens the duration of management, and it, of course, gives a better outcome.
So does this happen?
It does happen. Of course, I know historically or traditionally it has not been happening, and where you have few medical personnel, for example, if you are in a district hospital and there is only a surgeon in that hospital, it is difficult for him to, because there may be no radiologist, there may be no pathologist. But in Kenyatta, where we work, what we have done over time is that we have created multidisciplinary teams for most of the cancer patients. There is one for breast that we do every Tuesday morning. There is one for hepatobiliary, that means liver, pancreas, and the biliary system. That happens every Tuesday. And then there is one general that happens every Wednesday morning. Indian market is, I think they have developed the medical tourism that really does market itself. I mean, probably this is the first time I am appearing in TV to say we can do all the surgeries that patients go to India for. But if you look at the television, most often you will, even website, you will see in Kenya there are medical tourist sites or groups that actually sell India. So number one is the marketing strategy that India uses, so that sells. And then you see when you do marketing and you have narratives, patients that come with better outcomes from India, and then you put them out there. And then, of course, unfortunately in Kenya, the medical sector receives, I think in the recent past, very negative images. So if you have a better narrative coming out of India and you have very poor narrative that comes from Kenya. And of course it is true sometimes that, especially where you don't have multidisciplinary discussions, then the patients may not receive the best of care, not because the doctors there don't know how to care. It's just that if you have a multidisciplinary discussions and approach to treatment of cancer care, the patient is not taken here, there, taken time, and probably treated late. So I think those are some of the factors that do make patients go to India. And it is true, especially like it's been stated, sometimes, unfortunately, the marketing in India only says that the cost is cheap. But you see, it depends on which context are you talking about, which cancers are you talking about. Because, for example, if you're talking about pancreatic cancer, and for pancreatic cancer, if you do a pancreatectomy, most often those patients go to ICU that will then add the cost. So you may think that Kenya is costly, yet it's not that. And then, of course, thinking about economies of scale, that over time in India, they have, because of the medical tourism, they have more, so they can easily, if you go to an hospital, they can easily reduce their cost, which may not happen in our hospitals because we don't have the volume to use. So some of that cost, maybe because of the market economy, I think most often is exaggerated. Because I know, for example, renal transplant in Kenyatta that happen so often is much cheaper than it is in India, although you will hear that it is cheaper in India. Even the pancreatic tumors that I'm telling you, I know it's cheaper. Of course, occasionally there may be colleagues that may exaggerate their cost. We really cannot deny that because we know it does happen. But the most common thing is the marketing, that I would say, marketing of the Indian market. Number two is the narratives that come from India. But we also know as doctors, because we see patients who come from India, that most often the outcome is not as good as it's being said.
In terms, you've talked about cost locally. What cost implications are people looking at when they're scheduled for surgery? What are the various issues or the various things that inform the cost of surgery related to cancer?
So number one, cost is, of course, you come for consultation, and consultation will be across board, like any other disease. Then two, you need tissue diagnosis, as I was telling you, and you need imaging. There are two critical things that you will do that will help you diagnose, because you need to have a diagnosis first. You need to know, what am I dealing with? That will require that I take part of the swelling or the tumor as a surgeon, which is called biopsy. And then the biopsy is taken to the pathologist. That is a cost, because the pathologist will require money for the lab. And because I may use things like a needle that is bought, that process may also require some cost. So that is a cost. The imaging itself will be a cost. Then after diagnosis, we need to stage. You need to say, to what extent has the cancer gone? That in itself will be another cost. So the staging may require maybe a CT scan of the chest or abdomen. That in itself is another cost. And the imaging may be more than one modality of imaging. So it may be CT scan, it may be an ultrasound, or it may be an MRI, depending on which is the modality that is best suited to diagnose the spread of the cancer in that particular area. So there's a cost of diagnosis, cost of staging. Then after that, if you're talking about the modalities of treatment, beginning with surgery, if you go for surgery, in public hospitals, the reason why the cost is low is because the surgeon is salaried, right? So there is no professional fee. Both the surgeon and the anesthetist will be paid by the hospital that has employed them, or by the government, for example. Then what the patient will therefore pay is the cost of the bed, the cost of this theater. Like if you come here, there are breakdown of costs: sutures used, gloves used, gowns used, the gases that are used. And so the longer time for the gas, the longer you take in theater, the more the cost. So there is a theater cost, right? And then, of course, after that, you go back to the ward, the drugs you will use. If there are complications and you go to ICU, then the cost of ICU sets in. But that is the kind of cost that you are looking at. For public hospitals, I said it will be basic. Depending on which public hospital, again, you are talking about, because level 6 tend to be a little costly than the other levels. Then, of course, private hospitals. Private hospitals, additionally, from the cost that you are talking about, you will then be paying the professional fee, because you will be going with your specific doctor that is not necessarily employed by the hospital. So you will get that surgeon will have to have resource, and the anesthesiologist also will have their cost.
When managing cancer, we know people have had to spend a lot to treat cancer, whether it's surgery, chemotherapy, radiotherapy. What are these things that contribute to the cost of cancer care as a whole, and particularly when it comes to surgery?
The bigger issue is, and I think that is what we are talking about, affordability of healthcare. When you're talking about is it worth it, like I think probably is known to most people, there are certain cancers that you will not operate because the cost and the outcome may not be worth going through that surgery. But if you have early cancer that is amenable to surgery, and therefore, number one, apart from just removing the tumor, there will be additional length of life that is added, then life is worth more than any money. But if you look at them in terms of a patient who is moribund, probably that the side effects of the surgery may be more than the patient can bear, then it may not be worth it. But most often, the patients that are taken through surgery are patients that can't withstand surgery, and surgery will prolong their life or improve on the quality of their life. And if you look at it, cost-benefit analysis, always surgeons worth their salt will take patients that the cost-benefit analysis favors the benefit rather than the cost. Because even if you're doing 50,000, for example, for surgery, in total, for example, you come to Kenyatta, the total cost may be between 50 and 100, or you go to level 5, the cost is about 50,000. There are people who may not afford that, right? And that is where, in my view, the government needs to come in. Because health should be a government thing. If you leave it to personal, even the people with higher income with private insurance, the insurance may go at one go. So I think that there is a need of looking at ways of pooling resources to help people. Because even if it is 50,000, as I said, I know patients where I was initially in Kapenguria that probably have to sell their cows or have to sell their land to get that 50,000. While in Nairobi, that may seem a very small amount. In some other parts of the country, it's a huge amount. So I think cost depends on which hospital you're going, what facilities will they use, what is the technical difficulties that will be involved in that surgery to remove your cancer. And of course, the hospitals, which ones to add up to cost of maybe supplies to get something to take care of the hospital itself. This patient had locally advanced breast cancer, meaning that it has spread. There is a wound, or it is attached to the chest wall. And so in this one, there's both a wound and it's also attached. And so basically, this patient has received chemo. Initially, it was intended to reduce the size, but the tumor grew while on chemo, which sometimes can happen. And so basically, what we are doing is improving quality of life by removing the wound and creating a wound that can be dressed in a better way than this one is. This one is also painful. So basically, that means we are doing palliative surgery.
How often do you get to do surgery for palliative reasons?
It has become rare over time, but it was the commonest. These days, I think in the last, let's say, 4 months, this is the second patient I'm doing palliative surgery on.
So does it mean people are getting diagnosed early now, or what has changed?
So let's say 10 years ago, 10, 20 years ago, maybe you do more of the what is called toilet mastectomy. That's what we're doing. Palliative mastectomy. But these days, the more often you do just curative mastectomy. Of course, that indicates that people come earlier than before. I would advise that for breast, the best is to do screening, because then screening will help in getting the disease even before it becomes a mass that you can palpate. Palpate means feel with your hands. In that case, most of the surgery that will be done will be curative surgery. And you can actually get surgery that then spares the breast. Because you can get, in the Western world now, because the screening is a national program, what then happens there is that quality of breast care is measured on the number of breast-conserving surgeries that you do, rather than the mastectomies that you do. So for us, I think we will still struggle, given the fact that we don't have a national screening program. I think the mess has given us at least some infrastructural footing, given that there are a number of mammograms that are placed in a number of hospitals. So they can actually be utilized for screening, but that will require that you place radiologists or radiographers in those places. And then that can then help us get screening program. But given that these things are actually digital, if you get radiographers that know what they're doing, they can send them to radiologists centrally, and then that can help in getting the breast cancer early, and then we will see a lot of breast conservation surgery. Men, if you are dealing with, let's say you have 100 cases of breast cancer, at least one of them will be a man. So one out of 100 will be a man. So that's one. Then secondly, because the breast tissue in the men is very kidogo, it's small. It means that it doesn't necessarily mean that it's aggressive, but because of the smallness, it may appear like it's aggressive and difficult to manage, because it will not take long before the whole breast is involved. Yeah.
Cancer remains a disease that causes a lot of anguish to many families, but there are ways and options of managing this disease. But prevention and early detection remains the best way of tackling this menace. Until next time when we discuss another issue that affects your health, I've been your host, Dr. Masi Korir.